Good afternoon, everyone, and welcome, and a special welcome to those online. I'm Cynthia Minkiewicz, Chair of the Department of Population, Family, and Reproductive Health, and it gives me great pleasure to invite all of you to our 16th annual Harper Lecture and to introduce our honored guest. Joining us today will be three of Paul's family, his daughters, Nene Edwards Harper and Jeannie Harper Jones, and his grandson, Justin, who is en route and will be here shortly. It's really wonderful to have you joining us once again this year in honor of your dad's memory and his so many contributions, both to our department and to the field of public health. And before we get started, as is customary, I'd like to share with you a little bit about the legacy of Paul Harper. He was a pediatrician, one of the founders of the population movement, and also a firm believer in prevention. He completed his MPH here at Hopkins and was appointed chair of the division and then the Department of Maternal Child Health from 1947 to 1970. And once again, I have to comment how remarkable it is for one individual to have chaired an academic department for more than 20 years. As the biography notes in the online invitation, Dr. Harper was truly a visionary teacher and a leader. And what the bio doesn't share is that his work is just so fitting to note in the context of today's lecture. The breadth and depth of his 1962 textbook, Preventive Pediatrics, Child Health and Development, not only talked about conditions that were well known around medical conditions and health conditions more broadly, but he was really focused on the social context that contributed to an array of emerging health problems. And that brings us to today. So delivering our Harper Lecture this year is Dr. Pat Ocampo. She's professor of epidemiology at the Dalla Lana School of Public Health at the University of Toronto. She also serves as executive director of the Shing Knowledge Institute, and she holds a Tier 1 Canada Research Chair in Population Health Interventions. Simply put, she is a force for good. She's a global leader in social epidemiology, and she's contributed so many methodological and theoretical innovations. Her work has included the design, implementation, and evaluation of interventions to address urban health inequities, as well as interventions that address the structural inequalities which contribute to larger systems issues. Her work, like that of Dr. Harper's, focuses on prevention at the population level. Dr. Ocampo has received numerous national awards from prestigious bodies, both here in the US and in Canada, for her research, mentorship, and teaching. And she's a fellow of the Royal Society of Canada and the Canadian Academy of Health Sciences. And we're always thrilled that Dr. Ocampo will continue to be part of our Hopkins family. She earned her Ph.D. in the Department of Epidemiology here at the school before joining the faculty initially in our department, where she rose to the ranks of being a highly regarded and sought after professor before heading a bit north. And to her credit, I learned last night that many of the community partnerships and collaborations that she established, including some in Baltimore, have continued to thrive over quite an extended period. While more than a few years have passed since you migrated north, as we reminisced last night, we're delighted and really honored to welcome you back as this year's Harper Lecture. So please join me in welcoming Dr. Pat Ocampo, who will speak on 3 decades of research on the social determinants of health, non-accidental omissions, and their harms.
Thank you, Cynthia, for that very warm welcome. And it really is good to be back and here. I feel very close to this department because the department was very formative in my own early career formative years. So yes, I'm going to be talking about 3 decades of research on the social determinants of health. And I have a couple of takeaways that maybe I'll share with you now, so you know what's coming. And the first one is kind of an obvious one that I think everybody knows, probably has contributed to the literature on inequities occurring pretty much everywhere globally. And the inequities are growing. That is, the health and the social inequities are growing. And they're a major focus of our public health research because I think we all want to do something about it. When it comes to trying to explain the causes of those inequities, there are some key omissions that we need to be aware of, and they create blocks to progressing in our being able to explain and create evidence, generate evidence to inform effective interventions, and also those omissions cause significant harm. So what we need is sort of greater intentionality among researchers to implement some of the known solutions so that we can create effective explanations and solutions for eliminating inequities. So to start out, I think everyone is familiar with this tragic story of the growing inequities globally. This Oxfam cartoon is showing how just 26 billionaires have as much as more than half of the world. And these are not independent events. It's not like billionaires are getting richer and people just happen to be getting poorer, but they are very much linked. And this trend has been happening for a long time. And Oxfam has been very key in documenting this. And also the COVID-19 pandemic exacerbated inequities. Here too, we have some statistics showing how 252 wealthy men have the equivalent of 1 billion, the wealth of 1 billion girls and women in Africa, Latin America, and the Caribbean combined. And also in the US, there have been impacts as well, impacts of inequities on premature mortality. So there are 3.4 million Black Americans who would be alive if in fact their life expectancy was the same as white Americans. So rather than showing you slide after slide of data, I think we can all accept that really inequities are everywhere, and these inequities are created by people and therefore should be reversed by people. And when it comes to our research though, even after 3 decades of research on the social determinants of health and billions of dollars of research, their causes and therefore their solutions are still poorly explained. So let's dig into that idea. In 1993, Dalla and Whitehead introduced their framework, which wasn't necessarily a framework to focus on inequities, although we tend to use it for that. Certainly, they were one of the first to introduce the idea of social determinants of health. And this is important because it goes beyond just considering individual characteristics when it comes to health and well-being and inequities. You know, certainly age and sex and biology matters, but it was important to note that social and community networks, living and working conditions shape the way in which those individual level risk factors manifest. And the general socioeconomic, cultural, and environmental conditions of a community and a municipality and a nation are also important in shaping health and well-being. 15 years ago, the World Health Organization released their landmark report on closing the gap in a generation, noting that inequities were everywhere, and there's an urgency in the need to reduce inequities because inequities harm everybody. And along with that report came this particular framework. And I think the advancement of this framework is that you can think of social determinants in maybe 2 buckets. The first one being the, maybe I should do this. The intermediary determinants of health. And these are the more proximal determinants such as behaviors, psychosocial factors, living conditions like income or housing, even healthcare. So these are the proximal social determinants, and probably 90% or more of our research on social determinants actually focuses on the proximal social determinants. The other bucket of social determinants is called structural determinants, and those are really the upstream drivers or the causes of the causes, and they are closer to the root causes of what is creating inequity. So here we have policies, social policies, society's culture and values, and those contribute to shaping inequities along different dimensions, whether they're economic, occupational, or educational. Here's where some of those inequities occur. and also shape some of these proximal determinants of health. So even though this is a busy framework and it has much more in it, and it's specifying some pathways, there's still some key information missing. So I'd like to turn to maybe a simpler framework to be able to discuss what's missing. So this is drawn from Dr. Stephanie Nixon's model of the coin model of inequality. So Dr. Nixon conceptualizes inequalities as being a coin, or the social structures and systems of oppression as being a coin with two sides. The bottom of the coin describes the experiences of oppression. So groups who are at the bottom of the coin experience oppression. They experience harm and deprivation, and they're disadvantaged not because of anything they do themselves, or sometimes yes, but not always. In part, they're disadvantaged because of their social location and how the system of inequality affects their group or treats their group and deprives their group. And in our research over the last 30 years, I think we've become really good at really focusing on those who are oppressed. We're great at documenting inequities. We're great at talking about what is wrong with people who are disadvantaged, what their circumstances are, where they live. I've certainly contributed to that research as well. And we focused a lot on the oppressed. And it isn't until recently where we've started to move up and then think about the coin. Name some of those social structures of systemic oppression that cause the oppression and the disadvantage. So, for example, if we did a literature search to look at some of those oppressions, like patriarchy, even capitalism or colonialism, we can see, now this is whether the word appeared in research in PubMed in the title or the abstract. You can see that around the turn of the century, we had just a handful every year who were naming some of these, who were naming the coin in some of these oppressions. And it wasn't until about 2015 or so that things started to take off. And now we're seeing more and more articles every year that are really focusing on the coin. So we're kind of moving up and focusing not only on the oppression, but also focusing on that social structure. So, and that's great, but there's still some additional information about the system of inequality that's missing. After all, the coin has two sides. And so we want to make sure we're focusing on both sides of the coin. And maybe we're curious about why some of this information is left out of so many of the frameworks that we use. And what are the consequences of these? I'm calling them non-accidental. They're not quite intentional, but they're also not unintentional omissions. So at the top of the coin, the other side of the coin is where we have power and privilege. And the groups who are in the top of the coin, they benefit from the privileges that they have. They didn't necessarily earn their privileges. That doesn't mean that they didn't work hard to earn their privileges, but it wasn't just due to their own hard work. In part, they had privileges because of their social location and their group membership. In addition, it's important to note that the individuals who have power and privilege actually work to cloak those privileges and their benefits. In part, it's to work to maintain some of the benefits that they receive, but also it's to maintain kind of a positive societal regard of their social group. And a lot of this is missing from our current frameworks. So it's important to include it because if they have power and privilege, they have a role to play in dismantling the systems of inequalities, but we don't often talk about them. We don't often talk about the coin, and we don't often talk about power, those with power and privilege. So if we go back to the Nixon coin, Nixon identifies several different types of oppression that might happen. So we've got class oppression, we've got gender oppression, we've got ableism, et cetera. You can see the coin. And then there's a corresponding group on each side of the coin, people who are oppressed, and then people with power and privilege. And they're related to each other. And they're related to, oops, I keep pushing the wrong button. They're related to the types of and the structures of oppression that are present in society that are driving some of these inequities. So I thought maybe we could go through one example, and that is, how does the coin work when we think about systemic racism? I suspect we might all agree that there is systemic racism in the society, so this probably won't be that controversial. And when we think about how structural racism works, it creates a bit of a pathway, or it follows a pathway all the way out to the impact. That is either the racial inequalities that we see or demonstrate in our research, or some of the inequities that we hear about, say in the news, et cetera. And that pathway starts with the coin, so those systemic oppressions. And so there's structural racism there. Structural racism works with other forms of oppression as well. Not all of them are listed here. Might work with patriarchy, colonialism, which has been active for 500 years in North America. Also with white supremacy, and together they create, if we go to the green box, the next step, stereotypes, and the next box, and attitudes based on exaggerated beliefs, distorted ideas, and these ideas are held by people, by groups, by decision makers, and they're embedded and reinforced by the oppressive power relations created by those structures. And they in turn contribute to discriminatory behaviors that happen at the individual level, institutional level, and in social policies and norms to create the inequities that we see. And so maybe one example I'll call out that I've had experience with recently is we have a speaker series on the, I work at a hospital, and so we have a speaker series on the practice of race correction. And I don't know if you know what race correction is, but race correction, put simply, is a practice in medicine which has been present for, over 100 years, where if you're giving a certain diagnostic test, and by the way, it goes through many body systems, so cardio, respiratory, gynecology, psychiatry, where you're giving a test or doing a diagnostic, and if you're serving a patient who's Black, you apply a particular correction to the result that you've gotten on your test. And the correction actually always lowers the risk of the individual. And so what happens is that somebody may be sick, but then you apply the correction and it lowers their risk, and they might be denied care that they need as a result. And recent studies in the US show that in the area of kidney care, there have been over 100,000, I thought 300,000 deaths that can be attributed to race correction. Now it's happening today. This is not something that's happening. I mean, it was happening long ago and it's still happening today. And although you have really smart doctors who know that race is social, they still are daily applying this race correction, which is based on the distorted idea that race is reflecting genetics or biology. So that's one of the pathways in which it can work. It can be unintentional and you can be complicit, or discrimination can be intentional. So as we go to the left in this pathway, we're talking about root causes. And then as we go to the left, we're also identifying some areas that tend to be less visible in our frameworks. And so I call them non-accidental omissions because they end up benefiting those who are holding privilege and power. And those who have privilege and power use some strategies. This is not the full list, and I'll talk about some more later, to maintain some of these non-accidental omissions. One is normalizing attitudes and beliefs about certain groups. So when I just talked about race correction, there are many examples of the ways in which race is used in a biological way in medicine, sort of normalized there. Gaslighting. So when I first asked some of the doctors, I'm not an MD, about, well, there's articles being written about race correction in the US. So do we do this in Canada? And right away it's like, no, we wouldn't do this in Canada. But, you know, medicine is the same. It's taught in the same way in Canada and the US. And yes, Canadian doctors do this. Again, it's built in, just even some of the machines, it's built in there. I just had a bone density scan. They asked me my race, which is unusual. In Canada, we don't do that. So I said, oh, why are you asking me my race? And he said, I have to tell the machine what race you are in order for them to use certain data. So there's race correction in bone density tests. Sort of moves to innocence. So what I just described was a bit of a move to innocence. Oh no, we don't do that. Like we wouldn't, the idea was we are better than those US doctors. We wouldn't do that. So this move to innocence that happens. And I want to say a word about white supremacy, because I know that white supremacy often is thought about, you know, what the KKK does. And yes, that is white supremacy, but that's not all that white supremacy is. It's very active in society, and it's a historically based, institutionally perpetuated system of oppression and exploitation. And it happens in many continents, in many countries, very much linked to European colonization of the globe. And the purpose of it is maintaining and defending a system of wealth, power, and privilege. And it's very tightly linked to both structural racism and to settler colonialism. And so white supremacy too is probably the more invisible of these three that are listed here. But if we do our little literature search again for title and abstracts, we can see that even white supremacy is now a topic of study in some of our literature, starting in about 2019. Oh, right. So I never showed you the how many articles or the pattern for structural racism. And you can see that one took off a lot earlier, and it's much higher than some of the others. So just in case you were interested to see how many articles were looking at structural racism. So I thought I might go through another example, and that's looking at how Indigenous communities are affected by systems of inequality. So the type of oppression, the specific type of oppression that happens that targets Indigenous communities in Canada is settler colonialism. Settler colonialism, I just grabbed this Wikipedia definition. In Canada, it's the continuation of the results of colonization of the assets of the Indigenous peoples in Canada who were already there when settlers first arrived. And sometimes the idea of settlers is understood as when they first arrived in North America a couple centuries ago, and that's it. And that's not true, because settlers, over the generations, settlers and their families have actually benefited from settler colonialism, the land theft and some of the other activities that are going on. And so settlers are very much a present day thing. As settler colonialism progressed, Indigenous peoples more and more were subjected to formal policies of forced assimilation and cultural genocide. And when I grabbed this definition, this picture came up. Now you can't see it very well, But I'm wondering if anybody knows what that is. Maybe you've been listening to the news over the past couple of years because some of the atrocities from settler colonialism have come forward, even if it's a teeny picture. Anyone know what that is?
Religious boarding school.
Boarding schools, yes, residential schools, yes. Residential schools began in 1880 and were a government-sponsored system supporting religious organizations, mainly the Catholic Church, to create boarding schools, and it was mandatory for Indigenous children to attend. And the idea was to assimilate children by disrupting their ability to be able to learn their language and practice their cultural practices. And frankly, it was more than that. The conditions were terrible. Many of the children starved. There were reports showing that the mortality rates were somewhere between 40 and 60% at these residential schools of these children. And the government knew, and the religious organizations knew, and they did little to change it. And what they did, in fact, was create mass graves that were unmarked and put the children there. So that is a form of erasure. There's a problem with that. I guess another form of erasure that I'll just share is when I was putting this together and grabbing this definition. When you look at Wikipedia and you look under residential school in images, so this picture was taken in 1901. Oh, does anybody know? This is an advanced question. You probably don't know the answer. When residential schools ended?
What was the question?
Well, when did residential schools end? When was the last residential school closed? I get it that you're not in Canada. Actually, many Canadians don't know. Do you know, David?
We're still operating on the Navajo reservation.
Oh, okay. Well, in Canada, the last one closed in 1996. But what you see in terms of images are these black and white photos only. Never see any photos from 1990s, never see any photos from 1980s, never seen any photos from 1970s and on. So that you're under the impression that was so long ago. You don't come away with the impression that people attended residential schools who were younger than me. And so again, that's another form of erasure. So there's some data on Indigenous populations that are used to document some of the inequities compared to non-Indigenous populations in Canada. This is the high school graduation rate, and you can see it is tragically low for Indigenous populations on reserve, but that's built in by design. Many Indigenous children have to leave the reservation in order to go to high school. They have to leave by themselves to go to high school elsewhere in a city. And so that's a bit of a disincentive to go to high school. And so therefore graduation rates remain low. Some of the other data that we have show that there are higher children's death rates and suicides compared to non-Indigenous children, lower income, worse housing, poor drinking quality, drinking water, undrinkable water, and so on. Actually, another problem that's created that is used by, governments, and again, those with powers, is sort of structured incompetence. So we don't have great data on Indigenous populations. It's the one population that we don't have great data on. And, we're great at talking about data now and AI, et cetera. But we have very poor data on Indigenous populations still. There was some collected around COVID, and this shows how Indigenous populations, that is First Nations, Métis, and Inuit, had more barriers to getting healthcare during COVID. Okay, so settler colonialism, again, some of the facts, and this is the short list, is it's been happening for 500 years. Some of the consequences or strategies in settler colonialism were land dispossession or theft, internal displacement, that is moving Indigenous populations to reserves, forced assimilation. We already talked about residential schools, taking children away from families. And that wasn't only in residential schools, But there was something called the 60s scoop, where in the 60s, Indigenous children babies were taken from their families, and Canadian families were able to adopt them. And there's still some apprehension going on in the child welfare system, where a very large proportion of those in foster care are Indigenous children. Denial of rights, the UN Declaration of Rights of Indigenous Peoples is not adhered to in Canada. And while a lot of people say, oh, well, we only did cultural genocide, actually, all of these activities align with the UN definition of actual genocide. And so some of the frameworks that come forward and talk about what are the determinants of Indigenous well-being will include colonization, and then some of the activities of colonization, like just talked about the 60s scoop, the millennial scoop, is what's happening now with child welfare system, the Indian Act, which established reserves, et cetera, took away women's rights, Indigenous women's rights to maintain their identities. So there's a lot of consequences and strategies of colonization here. There are other types of oppressions that are relevant for this population. The patriarchal capitalism, as we mentioned, racial capitalism, and also white supremacy should also be included in these frameworks. And again, you know, that question should be asked, why are these left out of these frameworks? So when it comes to settler colonialism, some of the tactics that settlers use to maintain status quo, to alleviate themselves of guilt, and to maintain kind of a positive social regard. And we talked about some of these already, you know, erasure, so erasing any pictures, not actually erasing, but not having the pictures of residential schools that might reflect, you know, recent decades. Temporal containment is another one. So suggesting that happened a long time ago with those pictures. That was around the turn of the last century. Sanitization, calling genocide, cultural genocide. Actually, that's related to another one here, which is definitional gerrymandering. So Canada was involved in helping to come up with the definition of what genocide is with the UN, and they lobbied to keep out cultural genocide and lobbied to keep out internal displacement from the definition, so that they could not, so that their activities could not be called genocide. There's some inversion of guilt and blaming the victim. So there have been some high profile homicides of Indigenous men and women, actually, either by civilians or police. And what happens is police or civilians say, oh, I needed to protect myself, even if that individual was unarmed, or even if that individual wasn't being all that disruptive. So again, blaming the victim, inversion of guilt happens often. So these are some of the strategies that are used to keep us from really seeing, and not just in research, so in society, seeing what's happening at the top of the coin and in the coin. And some of the harms that happen from these non-accidental omissions and strategies to Indigenous peoples in particular are that we have ongoing inequities. The problems aren't fixed. We're not talking about who should be involved in fixing the problems, or everybody who should be involved in fixing the problems. And so we have these ongoing inequities, ongoing practices of oppression, reinforcing a racial hierarchy when we report on it. That's kind of a research issue that we need to start rethinking. Intergenerational poverty and trauma, family dissolution, like I've talked about before, denial of human rights to Indigenous peoples in Canada, and ineffective solutions. And actually the harms aren't just to Indigenous populations. They're also to everybody. These strategies, well, we know there's evidence to show that when we have diversity and inclusion, we have a better society and it's more equitable. But when we keep practicing settler colonialism, then we really deprive everybody of experiencing a diverse society. And there's a high cost of maintaining this kind of oppression. There's certainly data to show that areas that are more unequal have higher all-cause mortality rates. Everybody does, even rich and poor. So oppression is costly to everybody. So back to our framework that we use and what is missing. If we were to try and modify this, which I did, and see what's missing and try and insert it. There we go. There's my poor attempt to do it. You might include some things like being more explicit about the different forms of oppression and exploitation that just go beyond education, occupation, and income that are important for generating inequities. And then you see these kind of red and yellow arrows and boxes, and that suggests that really oppression is working both ways. It's not just creating disadvantage, but it is also creating benefits for those who are holding power and privilege. So we want to be able to acknowledge both. So anyway, I know someone else can do a better job, but I think the idea is these things are missing, they're causing harm, they're not necessarily unintentionally missing, and we need to acknowledge that. And once we have a more comprehensive framework, then we're going to be able to not only understand what the root causes are of inequities, but we're also going to be able to know who should be involved in coming to the table and eliminating them. And I know that when we modify a framework like this, we're actually, it looks like we're adding more work. So now there's many more variables that we have to study, and certainly we can't do it all, and that's okay. But given that in the past, we spent 95 or 90% of our time looking at these proximal social determinants, maybe what we should be doing is, if we have to focus, and we can't do everything, focusing on the coin, focusing on those structures of oppression, and focusing on the power and privilege, those people who hold power to be able to make change more easily than people at the bottom of the coin. People at the bottom of the coin are pushing for change, but they can't do it alone. And that's why we still have inequities, and that's why inequities are growing. So if we had to focus, let's focus more on the coin and the top of the coin, because for too long this has been neglected in our research. So just a brief summary of what I've said so far, and that is that our frameworks explaining the causes of growing inequities non-accidentally leave out the structures of oppression that are generating inequities, and also the privilege and power held by those with unearned advantages and privilege. And these non-accidental omissions cause profound harms. And these root cause structures are left out of public discussions and research frameworks. Again, because those with power and privilege use some of these cloaking devices to maintain high self-regard, high social regard, alleviate themselves of guilt, and to enjoy the benefits and to maintain the status quo. Yet without engaging with that top of the coin, we cannot generate evidence for and design effective inequity elimination initiatives. So I'm hoping to wait until 1:20. Okay, so one more example, and that's about intimate partner violence. Intimate partner violence refers to a pattern of behavior within intimate relationships that involves power and control by one partner, and causing physical, psychological, sexual harm to the other partner in the relationship. And it's quite prevalent. 1 in 3 women will experience intimate partner violence in her lifetime. And a lot of the research, as I just mentioned, focuses on kind of the individual level determinants, or maybe the determinants that may describe either the perpetrator or the couple, bad communication, power dynamics between the partner. But if we don't actually look at the root causes, When we leave that out of the explanation, we can't see how partner violence isn't so unique. In fact, it's related to other kinds of gender oppressions that individuals who identify as women are experiencing. Like right now, there's state control of reproduction. Women don't have control over their own reproduction, and that is a form of violence. There has been over centuries a form of wage theft when women or even men, when they're involved in the care work at home or the reproduction, are not paid for any of that. And so there's also some examples from the 40s and 50s where there needed to be some disciplining of women when they're not doing and appreciating their household roles. And so lobotomies were given to women who were not doing their housework, and something like 85% of the lobotomies given in the 40s and 50s were to women. And the indicators of success were they able to do their housework better with a better attitude? So, and if you go back, it's linked to the witch hunts, believe it or not. So this is another story, another talk about how all these types of violence are related and why. By the way, there still are witch hunts today. And that was also a form of disciplining, taking some rights away from women and opportunities for them to earn their own income, but also a form of disciplining. So partner violence is related to other kinds of violence, and we see that again, in this pathway that's created when we identify the kinds of oppressions that we're talking about here: male domination, sexism, misogyny, again, creating distorted ideas about women, like, it's natural for women to want to nurture and do the housework. Actually, that was socialized. And again, women were disciplined to have to do that. There's all of these come together to create discrimination against women. And there's a whole host of outcomes that result as a consequence of these root cause oppressions that we can name. So patriarchy then creates these built-in biases against individuals who are not men. And one of the ways that it creates these biases is when we think about many policies, they're actually gender blind. Men and other genders have unique needs, but if policies are gender blind or designed in that way, they're usually designed to meet men's needs, and the needs of the other genders are not considered. So let's just think about homelessness, for example, because there's a whole host of homelessness services that are available. And there are unique pathways into homelessness. For men and for women, these are some of the top causes contributing to homelessness. And you can see that the list is different. And it isn't that there isn't any overlap at all, but the needs of women and gender diverse individuals is different from men if you want to either get them out of homelessness or provide services. And given that most services are gender blind, there are consequences to ignoring the needs of women. And some of the harms that come about are that services are tailored for men and they're often unsafe for women. So homeless shelters, for example, are often designed for men. They often don't take women's children, or they don't protect women, so women feel unsafe there. Rooming houses have also been evaluated and shown that women feel very unsafe in rooming houses, often because there's no consideration of the safety of the participants when these services are designed. Services often neglect women's priorities. So she has her children with her, or she might be experiencing trauma, and the services are not trauma informed. Services that do actually meet women's needs, or especially gender diverse individuals, they're non-existent or they're chronically underfunded. And so there's just a small number of slots available to women. There's a lot of victim blaming that goes on when women don't use services. And people claim they're available, but women aren't using them when in fact they just don't fit their needs or meet their needs, or they feel unsafe. And research is guilty in neglecting the issue of women's homelessness. I was part of a very large, the largest actually randomized trial of homelessness using kind of a housing first homelessness elimination strategy. And because it was so large, we had one of the largest samples of women who were homeless who were receiving housing first. So we thought, wouldn't it be great to contribute that the analysis of the women's data to the literature? When we wrote the article, reviewer after reviewer in journal after journal criticized our work and rejected it immediately because there was no male comparison group. And they apparently didn't see any value in doing a woman-only analysis to understand the variability among women. Took us 6 years to get that published, and we kept getting that same comment. Even editors, after we did the revision and resubmitted, the editors came back from one journal and said, well, we just have to side with this reviewer who said, you don't have a male comparison group. So the quality of the study was substandard. So there's kind of these attitudes that permeate against understanding women's situations. So if we don't want gender blind, what do we want? We might want gender sensitive, which is a step up from gender blind, that is acknowledging that there are differences. But I think what we really want is gender transformative, because gender transformative understands and tailors services to the unique needs of all of the different genders. And so we kind of center the needs of all the genders and redistribute resources so that everyone is having their needs met. And recently, there's been some really great research using a gender transformative approach. There was a national quantitative and qualitative study done on homelessness and violence in Canada, showing that, yes, chronic poverty is linked to housing stability. That's not a surprise, but this was linked to and reinforced by many other issues. For example, safety concerns, because 75% of women and gender diverse people who are homeless are survivors of abuse. That issue of safety, which often isn't dealt with in any services, is a big looming issue that can either send women back to their unsafe home or keep them from leaving because they're worried about safety. And relationship breakup is one of the primary reasons for women entering homelessness. In Canada, 600 women and children are turned away every single day from services. And so you can imagine there isn't capacity to serve everyone who needs them. The other important issue is that while chronic poverty was present in those who had housing instability, for some reason or many reasons, they were really unable to access government benefits if they were eligible for. Now, that may not have solved it and made sure that they were housing stable, but it certainly would have contributed to the solution if they had accessed that. An adjacent problem to the chronic poverty and housing instability is the high risk of eviction and the challenges with individuals to access services to help them manage the eviction and avert eviction in a timely fashion. And women and gender diverse people were not able to access emergency beds. Now, throughout this whole pathway, discrimination was present, discrimination against women or class or for different reasons, as was disability status played a role in contributing to this pathway. So using kind of an anti-oppression approach, that is addressing power and kind of dismantling power in the research process, and also thinking about power as it's present and influencing what you're studying. Also having research that is led by those affected communities, because in this case, this research was led by those with lived experience. And also using the findings to take action. So since this study, they've actually taken action to try and make legislative and other changes to change these situations. So those are all kind of anti-oppression approaches, which contribute to being more gender transformative in this case. And so acknowledging that the key challenges in part are due to multiple types of oppression, and that the solutions can't be siloed because all of these things are happening simultaneously. And we need linked services in order to address them. And that was important. And we also took some of these findings away and created a program that we're working on right now. And it's called Safe at Home. And it's premised on the idea that when women are fleeing partner violence now, it's the women and children who are expected to leave the home if they want to stay safe. And when they do leave the home, that's when the risk of homelessness arises, given the number of people I told you are turned away each day. And there's social and community connections that are severed both for children and women. And that's sort of the expectation that seems unavoidable if women and children want to stay safe. The program that we're creating, though, takes that idea, kind of turns it on its head, because in the Safe at Home program that we're creating, the perpetrator actually leaves the shared home, and the survivor is given the opportunity to either stay in that home with her children or in another home of her choice. And she's able to safely stay there because she's provided access to safety strategies, tools, and technology to stay safe, and also by a whole host of integrated services, health, social, police, legal, financial, children's services, to kind of help them stay and start the recovery process. So Safe at Home kind of addresses all the dimensions of housing. Too often when we think about housing, we just think about shelter or a roof over your head. But this deals with not just the physical, but the locational, ontological, psychological insecurities that individuals with housing instability often experience. And it kind of restores women's right to housing, which right now is not guaranteed. And, it's centering women's needs, validating their perspectives, and helping them directly address the impacts of violence. Now, Safe at Home doesn't replace shelters. We need shelters for some individuals who are experiencing very high levels of violence, but it's an added option that doesn't tax the system, and it's women can choose that according to their circumstances. So our approach to Safe at Home has been using kind of an anti-oppression approach to disrupt power. It was initiated by survivors and it's co-led by survivors now. And as an academic partner, our role is to kind of support survivors and the community as they create this initiative, and we will help co-design an evaluation to determine how successful it is. So I think the last thing I want to say, just to wrap up, is that learning these approaches to kind of name oppression and to really get at the root causes in our research and to think about how we're going to do things differently, even on our own research teams, is not a recipe. It's not following a recipe. It's not a checklist, but it is more of a journey. This suggests that it might be a smooth journey, but it's not a smooth journey. Many times you're going to be sitting in discomfort, realizing what some of your old research has done and some of the harms that have been done, and kind of sitting with that, even if you're not comfortable. But there are resources available, and I thought I might put them in here, but I thought no, because it's not really a recipe or a checklist. I urge you to consult them, but not to think about them. I just have to do these 3 things and then I'll be all set. So don't think of it as a recipe or a checklist. Definitely think about it as a journey. And so we need to consider these systems of oppressions, the harms that they're creating, the ways in which they might be cloaked in our research frameworks on the social determinants and population health, because they do act as roadblocks to creating effective solutions. We need to take action on the coin and the top of the coin. And it really requires engaging with power dynamics. It's not just a matter of knowing what to do. And everyone has a role to play in coming up with better explanations that identify root causes to inequities and taking action on them. So as researchers and educators and trainees, we all have a role to play to really be intentional, to start our own journeys. We're starting in different places, to access some resources that are coming out, to join the people who are starting to really dig deeper into the coin at the top of the coin, so that we can create strong evidence to really dismantle oppression in our research and in society. So I'm happy to take any questions that you might have.
Students want to ask, defer to the students.
There's somebody with, a couple of people with their hand up there.
Students.
They're not students. Always
Thank you for that very stimulating presentation. And I have one question to you and then a couple of observations. One question is, what percentage of the Canadian population is Indigenous? You mentioned it in your second bullet on your last slide, kind of. The way to address gender equity is to get more than 44% of House of Representatives in the United States women, at least 50-50, same in the Senate, same in the White House, same in the governorship. All those things you're talking about, if women were in power, not address power dynamics, but be power dynamics, could address many of those issues. I also think that's the issue. So you're kind of missing the demographics. So, you know, the far right, voter suppression, grand replacement, they all realize that their days, demographically speaking, are numbered. And that white males are going to be much less powerful as a result of the enfranchisement of people of non-white people and women. And to me, I think that's missing in a lot of your presentation.
Thanks.
Much of what we're talking about is political power.
Yeah.
Who is making the decisions? And I think until that happens, we're going to be on the periphery. So, and I think that's a disadvantage. I don't know what the percentage, but I think that's a disadvantage facing small groups who are being treated in horrible ways.
Yeah.
Because they lack the political clout.
Sure. Thank you for your comment. I guess I'll try and give brief responses. So one question was, what proportion of the population in Canada is Indigenous? I guess you didn't say what year. So if we want to go back 500 years, it was much more, right? More than settlers. And in fact, settlers had power, as you mentioned, and because of genocide, the proportion is now very small. It's about 5% now, current day. But there was a time when there were many more. You know, I think this issue that you're talking about is not just about numbers, because numbers alone don't give power. So the framework that I'm trying to promote here is that some of the beliefs that we have that take away power or suppress power in populations are, you know, here among the distorted ideas or the exaggerated beliefs and the attitudes. Anyone can hold those. Women can hold those as well. They can also hold on to ideas that maybe they're not worthy of running for office or that they're not talented enough. And there have been a number of studies saying that women don't go for some of the corporate leadership positions because they want to make sure they're more than qualified before they apply, and white men don't feel the same way. So it isn't just a matter of numbers. We have to do more than, I guess, affirmative action. We actually have to change some of these attitudes and beliefs that lead to the discriminatory behavior. So I would add to what you're saying. Numbers are great, but we also have to change those beliefs, erroneous beliefs and erroneous attitudes. There's some people online, I think. Oh, no hands now?
Online. Lots of comments, but
Okay.
Oh, do you want to read any student
Yeah.
comments?
for all students.
well,
Really thank
all
you for the
students.
presentation and being very thought provoking, but not specific questions.
David?
Well, I was a student many years ago.
Many.
Thank you for a great lecture. Three things I would mention. First of all, your presentation pairs greatly with a book I'm reading called Caste. And
Oh, yes.
Caste is a great book for anyone who wants to unwrap this situation of oppression.
Yeah.
And caste is a disease that infects almost every civilization. The authors there speak about religion being one way to create caste and oppression. And they cite Hinduism actually. And they talk about Nazism and doing it in a capitalist system. And of course, they were very fascinated by our own system. So they worked very diligently. In fact, the Nazis couldn't believe how well we had been able to gaslight and cloak our oppression. So all of those terms move back and forth between your presentation. So that really is extraordinary. The other thing is you've unwrapped something that I think is very important and unaddressed sufficiently in any area of work, but in public health. And the person I think who did it well on a political basis was Jesse Jackson, because what he did was take a rainbow coalition instead of dicing and slicing the population, which we do. To me, the issue is oppression, casteism, and the poverty that's associated with it. So it's very hard to gain political power. Thirdly, the New York Times this weekend had a great piece on the Sackler group, the opioid group,
Oh, yes.
and their ability to permeate the Institute of Medicine. I who have worked in the nutrition area know the pernicious basis of industry and politics in modifying nutrition programs and really creating public policy that's antithetical to the well-being of the population. And we haven't paid enough attention. And your talk is long overdue in terms of trying to reconfigure how we think through the politics. I think some of the internationalists see it better because it's somewhat more apparent in colonialism. But the colonialism is with us in the US and in virtually every country. And it's a constant battle between good and evil.
Yes.
I think we're good, but we see it throughout the world right now. So I just want to make those observations, but strongly suggest the book Caste.
I have read it and I
Have you
agree
read
with
it?
you. Yes.
Yeah.
I have a recommendation for you that I can tell you.
Thank you. Thanks. Thanks for getting my polemic.
What a wonderful presentation, Pat. Just really want to thank you for being here today and giving us a strong challenge to really think much more upstream and much more intentionally. So please join me in thanking Dr. Campa.